Thank you. Over the course of the pandemic, public health officials worked with limited and constantly evolving and changing information to keep Americans safe and implemented policies that helped our nation overcome the virus. You know, we talk about off-label uses of medications as a physician. It's something we do, but we also do it with caution. And we do it in respect of science, in search of the evidence to help us determine whether it's a sham or whether it's a real medication that has proof. And the whole scientific process is to move us from anecdotes to the statistical realm so that we can prove and replicate that our results are not due by chance, but that within a 95% confidence that they are truth, that they will happen, that this actually works. So it's not anecdotal, or if it just happens with this one time it works or not, or maybe a group of 10 patients or 50 patients and we swear by it, but so that we can get to that truth. And I do believe that all of you had mentioned something very important that was common is I wish there were more studies, or we need more studies, or even in these off-label uses, the studies refute its use and it really didn't work, so we stopped using them, okay? So at the beginning of this pandemic, there was some anecdotes, some suggestions with bench research perhaps on some of these medications, but then we with caution, said, be careful, let's do more research. And then as the research developed, then there would be some recommendations, and the medical societies, the boards, the people that certify our board certifications in all of our respected fields, physicians, our colleagues, those that aren't running for office or anything, put certain parameters based on that research to give us some kind of gold standard of practice so that we can abide by. And those, your colleagues, my colleagues, his colleagues, all of our colleagues who are the professors in universities and the researchers gave us these recommendations and said, look, if you want to be a board certified and hold up to our standards, we believe that the scientific literature will recommend this and not recommend that, and this is what we believe at this time. At this time is always key, and it's always important because we must be humble to the fact that science evolves and things change. And we're using that now to even understand long COVID, to determine what are the commonalities and how to treat it, because the symptoms they're realizing because of the science is real. And there is such a thing as a long COVID syndrome. And so we're evolving in that aspect, and we're evolving in understanding the science to develop more therapeutics in addition to the vaccines, so that when people do have a breakthrough symptomatology, that even after a vaccine, that they have the treatments to be able to limit the intensity and the duration of illness. It's just science. It's what we're trained to do. It's what we want to look at to see if there's evidence about that. All of us participated in journal clubs during residency, and we learned how to analyze that science. So this is, this is what has evolved. It's not a, government conspiracy to come and suppress the physicians or the physician's ability to think independently or to interfere into the patient-doctor relationship. This is a practice amongst our colleagues of saying, well, let's look at the data. Let's look to see what is out there. And as it evolves, let's give these the recommendations. And on a clear example of that, and in search of this science, our goal was to get a vaccine. We're waiting for a vaccine to help us reduce the transmission, for many, prevent getting sick, and for the rest to reduce hospitalizations and intensity and duration, so that we can put kids back in schools and people back in jobs and come back to a new normal, okay? And so the notion that or the general notion that the federal government sought to subvert physicians and erode the doctor-patient relationship during the pandemic with even the vaccine requirements is just not true, and it's not helpful when we know that the vaccines are best arsenal to help eliminate the spread of a dangerous virus and to protect the public's health. So as a physician, I'd like to start by with the COVID-19 vaccine requirements questions. And so, Dr. Shane, why were requirements a clinically appropriate tool to boost vaccine rates, especially amongst high-risk individuals in high-risk settings, which is not a new notion? We've done it before in many different settings. And how have they been used in contexts outside of the COVID-19 pandemic to reduce the threat of other dangerous diseases in the United States?
So thank you very much for that question. During the COVID-19 pandemic, as we know, as you mentioned, we were all waiting for a vaccine. And the reason why the mandates were so essential at that particular time was that we needed a rapid way of ensuring that people got vaccinated. And certainly there was a lot of communication about the benefits, and with everything, there's always a risk, so communication about the risk as well. But the mandates or the requirements were really an optimal way to ensure that the vaccine reached the most number of people. And in addition, that requirement also allowed for improving access, which was a clear and important issue as well.
Thank you. So thanks to the policies that President Biden put in place, including these common sense vaccination requirements, more than 230 million Americans got vaccinated. 3.2 million deaths were prevented. 3.2 million deaths were prevented. And 18.5 million hospitalizations were averted. And when pandemic-era vaccine requirements were challenged in the courts, America's leading medical societies, our colleagues, the physicians that certified your practice and your training and residencies and to ensure that all of our practices are up to our current standards, including the physicians in the American Medical Associations, the physicians in the American College of Physicians, the physicians in the American Academy of Family Physicians, the physicians in the American Academy of Pediatrics, and several others, all expressed strong support. The physicians expressed strong support for these policies as a critical tool to help America overcome the pandemic. So, Dr. Shane, as a physician, do you agree with the allegations that doctors were sidelined and that the physician-patient relationship was disregarded in the discussion surrounding COVID-19 vaccines requirements?
So thank you. I do not. Desperate times calls for desperate measures, and the vaccine requirements were the optimal way to enhance that. Despite the requirement, there were lots of opportunities for physicians to communicate with their patients and families to ensure that there is a good understanding of, as I mentioned in my statement, the why behind the rationale. And that is what is so important, is making sure that people understand the why and the rationale.
And there are some patients that we would recommend not to get the vaccine. There were some contraindications based on the studies and the histories that should not get the vaccines. Do you agree with the characterizations of COVID-19 vaccine requirements as a one-size-fits-all protocols that undermine the quality of care Americans receive from their physicians?
No, I do not, and especially since I take care of children of many different sizes, I certainly couldn't have a one-size-fits-all approach and had to tailor all of my recommendations based on the patient and their condition.
You know, I'd also like to address the suggestion that population-based health approaches undermine the quality of care that a physician can provide to their individual patients. Dr. Shane, in your written testimony, you state that, quote, supporting population-based health measures does not run counter to providing optimal care for our individual patients. You note that community-based measures prevent infection, hospitalizations, and death, thereby benefiting individuals who stay healthy as a result. So how did population-based COVID-19 public health measures, such as masking and other mitigation measures, safeguard individuals' health during the pandemic?
So thank you for the question. Those mitigation measures both had an impact on the individual and in addition to the community. So when individuals are healthy, that means individuals comprise communities, and communities are healthy. And the vaccinations were one, masking, separation when needed, having people stay home when ill. Those were all things that we had to do to flatten the curve and to make sure that we could bring ourselves back to a society that was enabled to have the normal interactions.
Thank you. You know, I have both a doctorate in medicine and a master's in public health. And the practices, although overall achieve the same objective, a healthy individual, a healthy population, there are some practices for population health that, and the understanding of that field that's different than what we learn in medical school. And so I think that that's why there's oftentimes a lot of confusion trying to extrapolate individual care to population care and the vice versa. And so there is a profession and a goal to keep a population safe as it relates to the individual care. And they're not incongruent, but they are different. So one final question for you. How does the work of our public health institutions complement, as opposed to undermine, a physician's role in providing the best care for their patients?
So thank you for the question. That's actually very critical. And the clinician has a perspective, the individual perspective, and then the public health institutions have a different perspective. And so bringing those two together is the best way to ensure that we have policies and recommendations that take into account both the individual and the community. Thank you.
Thank you, and I yield back.